Our next presenter will be Dr. Shin Fujita from the Department of Surgery, Tochigi Cancer Center, presenting Abstract 3508, a randomized trial comparing mesorectal excision with or without lateral lymph node dissection for clinical stage 2 and 3 lower rectal cancer.
Thank you, Chairman. I'm very pleased to present this interesting trial at ASCO 2016 meeting. Metastasis to lateral pelvic lymph nodes occasionally occurs in patients with clinical stage 2 or 3 rectal cancer, and therefore lateral lymph node dissection is a standard procedure in Japan. Lateral pelvic lymph nodes are the internal iliac, external iliac, common iliac, and obturator nodes. However, evidence is insufficient to perform LLND for rectal cancer patients without clinical lateral lymph node metastasis. This study aims to determine whether or not mesorectal excision alone is non-inferior to ME with lateral lymph node dissection in terms of efficacy. ME with LLND is a standard procedure in Japan, so this study is non-inferiority trial. Patients with resectable clinical stage 2 or 3 lower rectal cancer without lateral lymph node enlargement were enrolled. After mesorectal excision was performed, patients were intraoperatively allocated to undergo mesorectal excision with plus lateral lymph node dissection or ME alone in a randomized manner. Adjuvant chemotherapy was given to patients at pathological stage 3. Neoadjuvant chemoradiation is widely used for rectal cancer patients, but in this study, neoadjuvant chemoradiation was not used. This is a very important point of this study. When the protocol of this study was developed, the efficacy and safety of preoperative this is a very important point of this study. When the protocol of this study was developed, the efficacy of safety of preoperative chemoradiation for rectal cancer had not been demonstrated, and adjuvant radiotherapy was not commonly performed in Japan because in Japan there were fewer cases of local recurrence with relatively favorable prognosis compared to other countries. This slide shows the eligibility criteria for this trial. These three criteria are very important. The incidence of lateral pelvic lymph node metastasis in clinical stage 1 rectal tumor is very low, so clinical stage 2 or 3 tumors were included. Lateral lymphatic flow of the rectum exists below the peritoneal reflection, and metastasis to lateral pelvic lymph nodes from the tumor located above the peritoneal reflection was very rare. So tumors located below the peritoneal reflection were included. And the diagnosis of lateral pelvic lymph nodes enlargement was performed by CT or MRI, and slice thickness was 5 millimeter. Lymph nodes more than 10 millimeter in short axis was defined as lymph node enlargement in this study. The primary endpoint was relapse-free survival. The secondary endpoints were overall survival, local recurrence-free survival, incidence of adverse events, operation time and blood loss, incidence of sexual and urinary dysfunction. Today, I will show you these three survival results. This slide shows a summary of operative details and safety. This result was presented at ASCO 2011 meeting and published in Lancet Oncology 2012. Operation time was longer, significantly longer, and blood loss was significantly greater in the ME plus LND group than in the ME group. Grade 3 to 4 post-operative complications occurs 76 patients in the ME plus LND group and 56 patients in the ME group. The incidence of grade 3 to 4 post-operative complications was higher in the ME plus LND group than in the ME group, but the difference was not significant. Sample size was 700. Non-inferiority margin of the hazard ratio was 1.34. Planned accrual was 7 years. Actual accrual was between June 2003 and August 2010. 201 patients were enrolled and randomly assigned intraoperatively after mesorectal excision. 351 patients were assigned ME plus LND, and 350 patients were assigned ME alone. All but 3 patients underwent surgery as allocated. One patient in each group with liver metastasis identified after randomization underwent hepatic resection following rectal cancer surgery. And one patient in the MA group in whom lateral lymph node metastasis was strongly suspected and so underwent lateral lymph node dissection. 6 patients in ME's plus LND group and 7 patients in the ME group were ineligible. However, all the patients were included in intent to treat analysis. Patients' characteristics were similar in both groups. Median of tumor distance from anal bulge was 5 centimeters. This slide also shows patient characteristics. Patients' characteristics were similar in both groups. About 20% of the enrolled patients were pathological stage 1. 14 patients had microscopic or macroscopic residual tumors. This is a result of the primary endpoint. In the ME plus LND group, the 5-year RFS was 73.4%, and in the ME group, the 5-year RFS was 73.3%. The hazard ratio was 1.07. The upper limit of 90.9% confidence interval was above the non-inferiority margin of 1.34. So, non-inferiority of ME alone to ME with LND in terms of relapse-free survival was not confirmed in this study. This is the eligible patient analysis. The hazard ratio was 1.05, and p-value for non-inferiority was 0.045. In the eligible patient analysis, non-inferiority of ME alone to ME with LND was demonstrated. This slide shows the overall survival of all randomized patients. The hazard ratio was 1.25, but the difference was not statistically significant. The 5-year overall survival in both groups were more than 90%. This survival was very good. This slide shows the local recurrence-free survival of all randomized patients. The hazard ratio was 1.37, but the difference was not significant. We classified local recurrence sites into 3 categories: central pelvis, lateral pelvis, and anastomosis. In this case, local recurrence was found in the central pelvis, here. In the ME plus LND group, the number of patients with local recurrence was 26. In the ME group, the number of local recurrence was 44. The proportion of patients who developed local recurrence was significantly lower in the ME plus LND group than in the ME group. Among all recurrences in the lateral pelvis were significantly fewer in the ME plus LND group than in the ME group. This is a subgroup analysis of RFS. As shown in this slide, there was no interactions among groups. In conclusion, non-inferiority of ME alone to ME with LND was not confirmed. ME with LND had significantly lower local recurrence, especially in the lateral pelvis, compared to ME alone. These findings support the validity of ME with LND as the standard procedure for lower rectal cancer in Japan. Finally, I would like to acknowledge all the doctors in the participating institutions and the members of the JCOG Data Center and the JCOG Operation Office. Thank you for your attention.
Thank you, Dr. Fujita, for that great presentation of a very large trial.